Welcome back to another deep dive. We are cutting straight to the chase today because we have a massive topic to cover. But before we get into the weeds, I have a quick favor. If these revisions are helping you, please take 2 seconds to rate the show. It genuinely helps us.
It really does.
Also, if you're serious about passing, you need to go get the premium subscription. Right now, it's the only place you're going to get the Journal Club and clinical cases deep dives.
And that's where the high-level discussion is, really. The Journal Club episodes are specifically designed for that critical analysis section of the Viva, so don't sleep on those.
Exactly. And last thing, leave us a comment. We build the schedule based on what you ask for. All right, let's get to work. Today we're tackling a cornerstone, craniosynostosis.
High-yield territory.
Absolutely. For the boards, for the FRCS, we're going to cover diagnosis, the Greek names, syndromes, surgery, all of it. So let's start with the big picture. Definition is simple enough. Premature fusion of sutures. But lay out the landscape. How common is this?
It's surprisingly common. We're talking about an incidence of approximately 1 in 2,500 live births. Now, for the exam, it's crucial to know that the vast majority, about 90% of these cases, are non-syndromal.
Right, so 90% are isolated, but the exams love that other 10%.
Of course.
So for that syndromic group, what's the genetic pattern we should have in our heads? I always feel like autosomal dominant is the safe bet.
That's a very safe bet. It's the standard for most of them. But there's always a trap, isn't there?
There always is.
And in this case, it's Carpenter's syndrome.
Carpenter's is the outlier.
Exactly. Carpenter's is autosomal recessive. If you remember nothing else about the inheritance patterns, remember that Carpenter's breaks that dominant rule.
Okay. And digging into the molecular side of things, we always see the same genes popping up. It's mostly the fibroblast growth factor receptors, yeah.
Precisely. FGFR 1, 2, and 3 are the usual suspects.
Yeah.
You'll also see TWIST and MSX2. It's actually quite striking. In Allard syndrome, for instance, we can identify a specific genetic mutation in almost 100% of patients.
So we have a fused suture. And the clinical problem is what that does to the shape of the head. This brings us to Virchow's law. I think of it like a water balloon. You squeeze one part, it bulges somewhere else. Is that a fair way to see it?
That is a perfect analogy. Yeah. Virchow's law basically states that skull growth is restricted perpendicular to the fused suture. So to make room for the brain, it has to compensate by growing parallel to it. And that's what gives us those diagnostic head shapes.
Let's unpack those shapes because this is where the terminology gets heavy. We'll start with the most common one, sagittal synostosis. What are we looking at?
Sagittal is the big one. It's 40 to 60% of all cases, and there's a strong male preponderance, about 4 to 1. Since the suture is midline, fusion stops the skull getting wider, so it gets longer.
And the term for that is?
Scaphocephaly, from the Greek scaphos, meaning boat. It looks like the keel of a boat. You might also hear dolichocephaly, which is just long-headed.
Okay, moving to the coronal sutures, this is where it gets twisted. Unilateral coronal synostosis. What's the result?
That gives you plagiocephaly. Again, from the Greek plagios for oblique or twisted.
And if both are fused, bilateral.
Then the skull can't grow forward. It becomes short, front to back. We call that brachycephaly. Brachys means short. And because the brain still needs space, it grows up.
So you get that tower skull shape.
Right. Pterocephaly or osteocephaly, meaning a sharper pointed skull.
Makes sense. What about the metopic suture, right down the forehead?
That gives you that very classic triangular shape, triganocephaly. You'll feel a ridge, and the eyes will look too close together. Hypotelorism.
And then there's the most severe one, when multiple sutures fuse?
That's the Kleeblatt-Shuttle anomaly.
Gesundheit.
It's German for cloverleaf skull. Try philocephaly if you want to stick with it. The skull is bulging out at the temples and the top because it has nowhere else to go. A very dangerous condition.
Okay, let's shift to the clinic. This next bit is probably the most common real-world scenario. A baby with a funny head shape. Often it's just positional plagiocephaly. How do we differentiate that from true synostosis? This is a classic exam station.
It is, and you have to be systematic. I always say look from the top down, the bird's eye view. You're looking at 3 things: skull shape, ear position, and the forehead.
Let's break those down. Shape first.
Positional plagiocephaly looks like a parallelogram, a rhomboid. It's just skewed. True unicoronal synostosis is more of a trapezoid or a triangle.
Okay, shape is step 1. Step 2, the ears. This is where people get confused.
In positional, the flattening is at the back, the occiput. That flattening pushes the ear on the same side forward.
Right, it's just a push. But intrusynostosis?
It's totally different. The fusion is at the front, so the skull base is affected.
Yeah.
The root of the nose points towards the fused side, and the ear position reflects that restriction.
And then a forehead. This is the clincher for me, the bossing sign.
Yes. In positional cases, because the pressure's from the back, you get ipsilateral frontal bossing. The forehead bulges on the same side as the flat spot.
And intrusynostosis.
It's the opposite. The suture on that side is fused, so the forehead can't grow forward. It's flat, recessed, so you get compensatory bulging on the other side.
Contralateral bossing.
You get contralateral bossing.
So, to recap for anyone driving, positional equals ipsilateral bossing. True synostosis is contralateral, that's the money shot. So if it's positional, we don't operate.
Almost never. It's managed non-operatively. Active repositioning, lots of tummy time, physiotherapy if there's torticollis, maybe a helmet in severe cases, but it usually corrects itself.
Now, if it is true synostosis, we're talking surgery. And it's not just cosmetic, we're worried about the brain. Let's talk about ICP-raised intracranial pressure. What are the red flags in a baby?
The signs can be subtle. Irritability, vomiting, failure to thrive. Physically, you're looking for tense, bulging fontanelles. On fundoscopy, you might see papilledema.
And if we miss it, the long-term consequences.
They're devastating. Blindness, permanent intellectual disability. You do not wait and see on raised ICP.
And the risk goes up with more sutures fused, right?
Strongly. For a single suture, the risk is around 14%. But if you have multiple sutures fused, that risk jumps to nearly 47%, almost half.
Which brings us to radiology. What are the signs on a CT?
At the suture itself, you'll see sclerosis, loss of that normal lucency, maybe some lipping. But then you look for the secondary signs of pressure. The classic one is the copper-beaten appearance on the inner table of the skull.
Because the brain is literally beating against it.
Exactly. And there's another specific sign for coronal synostosis on an AP film, the harlequin eye.
What's actually happening there?
It's a distortion of the orbit. The fusion causes the lesser wing of the sphenoid bone to be elevated. On the X-ray, it makes the eye socket look slanted, like a harlequin mask.
And quickly, why might we order an MRI in a syndromic kid?
To rule out other CNS anomalies, specifically, you're looking for an Arnold-Chiari malformation, consular herniation. You need to know that before you operate.
All right, let's move into the syndromes. This is the rapid-fire differentiation section. Let's start with Appert's.
Appert's, okay. Bicoronal synostosis, midface hypoplasia, and the absolute key identifier, the hands. Complex syndactyly. We call them mitten hands.
And it's not just webbing. We're talking bony fusion.
It's complex, yeah. We classify it into 3 types. Type I, thumb and little finger are free. Type 2, just the thumb. Type 3, everything is fused into a rosebud hand.
Gene.
FGFR2.
Okay, now croissants. Clinically, the face can look very similar. How do you tell them apart from the door?
Look at the hands again. Croissants patients have normal hands. That is the differentiator.
And the gene.
Also FGFR2. So the hands really are the clinical key.
Next one, Sathrachatson. What are the buzzwords?
For Sathrachatson, look for a low-set hairline, eyelid picosis, small ears with a prominent crus. They can have some syndactyly, but it's usually just partial, digits 2 and 3.
Not the mitten hand.
And the gene. This one's different. It's the twist gene.
Pfeiffer syndrome.
Broad thumbs and broad great toes. If you see wide thumbs, think Pfeiffer's.
And Muenke's.
Muenke's is almost defined by its genetic test. It's the Pro250 ARG mutation on FGFR3. And clinically, you should associate it with sensorineural hearing loss.
Finally, let's circle back to Carpenter's, the autosomal recessive one.
Right. These patients are often obese. They have preaxial polydactyly of the feet, so extra toes, and a very high rate of congenital cardiac problems. So obesity, extra toes, and a bad heart.
Okay, let's go to the OR, section 6. Surgical management, broadly, what are we trying to achieve?
4 main goals. 1, protect the airway in the corneas. 2, prevent the deformity from getting worse. 3, fix the deformity that's already there. And 4, reduce that intracranial pressure.
And why do we do this so early in infancy?
Physics and biology. The infant skull is malleable. The brain is growing explosively, so we use that brain push to help remodel. And bone defects. They just heal better before 9 or 10 months. They reossify.
So practically, what's the procedure for that common sagittal synostosis?
Usually a sagittal strip craniectomy. We remove the longitudinal strip of bone over the fused suture, releases the restriction, lets the head widen.
But for anterior problems, like coronal or metopic, a strip isn't enough.
Correct. For those, we do a frontoorbital advancement, an FOA. We take the bone above the eyes, the orbital bar, and advance it forward. Corrects the forehead, deepens the orbits.
Now, in Appert's or Crouzon's, we have to deal with the midface. We've got the Lefort third, but there's also the monoblock. What is that?
A monoblock is an aggressive procedure. We advance the forehead and the midface, all as one single unit.
That sounds massive. What's the big risk?
Infection. You're creating a direct communication between the cranial cavity and the nasal cavity, which is, full of bacteria. So there's a significant risk of meningitis.
But technology has moved on. We have distraction osteogenesis now.
Distraction is fantastic. Instead of moving the bone all at once, which stretches the skin like crazy, we cut the bone, apply a device, and slowly turn it, maybe a millimeter a day. It grows new bone in the gap and stretches the soft tissues gradually.
It's leg lengthening for the face.
Exactly.
We're nearly at time. One final gotcha fact for revision. The cranial index. What are the numbers we need to know?
Okay, a normal cranial index is about 76 to 78%. In sagittal synostosis, the long, narrow head, the index drops to 60 to 67%. In coronal, the short, wide head, it shoots up to 84 to 91%.
Low index sagittal, high index coronal. Boom. That's a wrap for our deep dive on craniosynostosis. We covered a lot of ground.
It's a dense topic, but if you can keep the syndrome straight and understand the why behind the surgery, you'll be fine.
Before you go, remember, rate the podcast. It helps us. And seriously, go get that premium subscription. The Journal Club this week is breaking down a key paper on distraction.
And leave a comment on what topic we should drill next.
Thanks for listening. Good luck with the revision.
Study hard.